So I want to ask just kind of point blank, I'm approaching 40 years old. You're a world renowned expert cardiologist, whether or not you want to call yourself that or not, I will. What is one thing I could change, or someone that's listening that are in my shoes or younger, older, either way? What is one thing that somebody could make a change to just improve their overall cardiac health from your perspective?
So usually, you said something you could do because I usually tell people that the most important thing to do is to pick better parents. Okay. Because so many of the things, even probably our response to diet and our response to a lot of things is partly dependent on who we pick for parents, how good you can get as an exercise and stuff like that. But if you ask me, probably the one thing, it's to keep.
Welcome to Last Known Vitals. My name is John Smith, and today I am joined by Dr. Paul Thompson. He's a cardiologist, Chief of Cardiology Emeritus at Hartford Hospital, and someone who has spent decades thinking about what actually keeps the heart healthy, not just in emergencies, but over a lifetime. He's authored more than 500 articles and has been a leading voice in prevention and exercise-based heart health. Dr. Thompson, thank you so much for joining me today.
Really, it's my pleasure. I like doing these sorts of things. So thank you.
So I found you on TikTok initially. I was highly entertained by your videos. I thought they were amazing, and I'm going to get to all that stuff. But I really want to start this interview off back when you first got into medicine, back at Tufts University. Walk me through the moment where you realized cardiology was your calling.
So in 1960, I watched the Olympics on TV, and I said to my friend Bobby Blanchard, "I want to go to those things." I mean, I already knew I was a reasonably good runner. So Bobby rode his bike, and the two of us ran. I ran about 2.5 miles up to a place called St. John's Prep. This is north of Boston, Danvers, Mass. I ran up to St. John's Prep to the track, turned around, and ran back home. And Bobby rode alongside me on his bike. Now, I ran like 5 miles when I was 12 years old, and now I couldn't walk for the next couple days. But I knew I was a good runner. I knew I had the capacity to do a lot of exercise, and so I got interested in medicine and ultimately cardiology, simply because I was interested in being a competitive distance runner. I wanted to be as good as I could be. I read all the books about exercise training. My favorite was the book about Herb Elliott, who won the 1960 Olympic 1500 meters. And Herb was an Australian, and he would run up sand dunes at Portsea on the western side of Australia. And so I would make my father, as a 12-year-old, drive me to Cranes Beach, north of Boston, that had all these sand dunes. And I would run up sand dunes because Herb Elliott did it. So I got into medicine and have stayed interested in it because I've always been interested in human performance. It also marked really what I did for research. Why did I go into cardiology? I went into cardiology because in those days, where did you use exercise? You used exercise doing exercise stress testing. You used exercise in cardiac rehabilitation, which was starting in those times. So graduated from college in 69, couldn't do much else in medicine that related to exercise except in cardiology. And then went on from there and then made choices along the way which were very useful. For example, in 1970, I spent the summer with a guy named Dave Costel at Ball State University in Indiana. If you're an exercise physiologist, you know the name Dave Costel. So what I did is I was end of my first year of medical school. I wrote him a note and I said, I'm this distance runner because I did compete as a distance runner, and I want to learn more about exercise. And he gave me American Heart Association grant for the summer. So I went to Ball State, lived there for 8 weeks. Really, what he wanted me for is he wanted me as a biopsy sample. So the study that I worked in, unbeknownst to me when I went there, is we did a study about how muscle loaded glycogen. So we would, and there were 5 of us who were subjects. So we would we'd get a biopsy. We'd go run 10 miles, believe it or not, get another muscle biopsy, do that for 3 days in a row, and then we ate a high carbohydrate diet and did it again to see if there'd been a change in the glycogen content of the muscle and how it responded to exercise. Now, the only reason I'm bringing this up is that all this interest in exercise, which continued through medical school, has turned out to be useful. For example, I did studies on how statins affect skeletal muscle, and I did a lot of muscle biopsies as part of those things. And I'd say to people, hey, this is no big deal. I've had 7 of those. Hey, you want to feel them on my thigh? And so I learned how to do skeletal muscle biopsies by being a subject. And by the way, the person who did the biopsies, a wonderful guy in Indiana, was a pathologist. So I'm being biopsied by a person who primarily takes care of dead people. The significance of that was not lost on me. But that's how I got into the whole thing. And then, I decided I wanted to continue in that. So I went into cardiology, as I told you. And then when I did my cardiology training at Stanford, and I went to Stanford because there were 2 very good exercise guys there. There was a guy named Bill Haskell, who was a PhD in exercise science, and there was a guy named Peter Wood, a PhD in biochemistry. Peter Wood was the first guy in the 1970s to show that distance runners had higher levels of HDL cholesterol, and Bill Haskell was interested in exercise in general. Now, why do I bring these up? I'm known for studies of sudden death during exercise, and what are the risks of exercise? That's one of my areas of interest. How did I get into that? I ran the Beta Breakers road race. Some guy died in the Beta Breakers road race. I decided to look into sudden death during exercise. There was a guy at Stanford named Mike Stern, an endocrinologist, great guy. He had collected like 8 or 9 cases of sudden death during exercise. I and a medical student collected 10 more and wrote it up in JAMA, which is the Journal of the American Medical Association, a very good journal. And all of a sudden, I went from being somebody who knew not much about sudden death during exercise, to writing that paper that was in a prominent journal. Now, here's the other part of it. And this goes to show that it's better to be lucky than good. This
Amen
is
to that.
this this is 1979, and Jimmy Carter is president. On September 14th, Jimmy Carter goes jogging on a very hot day and nearly collapses from heat overload. So the New York Times is going to publish on September 15th, it's a Sunday morning, front page, they're going to publish about Jimmy Carter's collapse. My paper is due to be published in JAMA on September 21. The New York Times calls Journal of the American Medical Association and says, can we move up that publication because President Carter has collapsed? I want to talk about the risks of exercise. So they move it up. Jimmy Carter's on the front page of the New York Times with Paul Thompson. So I go from being a fellow in cardiology to being a nationally known expert. We'll come back to what an expert means, but I'm a nationally known expert now in sudden death during exercise, which I just think is, an amazing coincidence. Now, I say expert because the definition of expert. It's a jerk from out of town with slides. So, I don't consider myself an expert because we don't have any slides today. But so that's the way my career has gone. It's gone along this exercise routine. Now I'll continue it a little bit. And that is that, so if you're interested in exercise, you're interested in skeletal muscle. So, well, one other thing that's kind of an interesting story. In the mid-1980s, I think it was 1984, could have been 86, but when I got to Brown, in Brown University, I recognized that the state of Rhode Island had only one medical examiner. Whoa, how cool is that? So if this medical examiner helps me collect everybody that drops dead during jogging, and I can figure out how many joggers there are in the state of Rhode Island, I can get the number of deaths per number of joggers. So we did that. We collected over a 6-year period. Bill Sterner was the guy's name. He's since deceased, but a wonderful man. Bill Sterner collected all those cases. I had a medical resident who would call up and interview the families. And then we determined the incidence of sudden death by doing what's called a random digit telephone survey. We had a computer that generated telephone numbers, and we had these women who would ask if there was a jogger in the family and how much they jogged and all that sort of stuff. So in 1982, I think it was, we were able to publish one of the first studies that gave the death incidence during jogging. Now, we found there was one death per every 7,000 joggers, so not very frequent, but anyway, there it was. Then I think it was 1984, Jim Fixx, the author of the complete book of running, drops dead jogging in Vermont. So 2020, ABC 2020, decide they're going to do a show on it. And so they came to me and said, we understand that you have the only incidence figure, deaths per number of participants, that's incidence. You have the only incidence figures on death during jogging. Would you help us prepare this thing? And so I helped them prepare the thing for 2020 on Sunday night and was in it. The plot thickens. Not long afterwards, I don't remember how long, but I get a call from a guy named Arthur Kaminsky. And Arthur calls me and he says, are you the guy that was the distance runner at Tufts? And I said, yeah. And he said, well, you don't know me, but I married your wife's roommate from Tufts. Okay. Arthur Kaminsky. Okay. I would like to be your agent. And I said, what do you mean you want to be my agent? He said, well, I represent people on television. And, I would like you to be like a commentator at distance events or things like that and talk about the medical parts of distance events because, you're a reasonable runner. We'll come back to that. And, obviously, something about cardiac complications during exercise. We can use you. So they use me. And I said, well, what's your take? And he says, well, I take 10% of anything you get. I'm like, hey, I'm not making anything. What's 10% of nothing? Good. Okay, I'm glad to do it. So he sends me a contract. I sign it. About 3 weeks later, I get called by ABC Sports and they say, we understand you're one of our commentators for the New York City Marathon. Huh? So, I've been on TV maybe once. So I fly to New York, actually first class. I didn't know there was such a thing as first class. In fact, I had hardly been on an airplane. So I fly to New York, first class, and I go into the ABC studio and I walk up and introduce myself. And they say, who do you make the check out to? And I say, Paul Thompson. And they said, no, 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 that's you. Who's your agent? And I said, oh, Arthur Kaminsky. And the place goes silent. Now, it turns out that Arthur Kaminsky is one of the best known. He's also since deceased, unfortunately. He's a wonderful man, a great guy, and the only person was interested in my career. Anyway, so because he, knew my wife and felt sorry for her, probably. So Kaminsky turns out, I saw a list of the 100 most influential people in American television sports, and number 17 was my agent, Arthur Kaminsky. And so he represented me and got me jobs at the New York City Marathon. I did 3 or 4 of them as a commentator, and then he got me a job working for NBC at the 1988 Olympics. So luck, somebody, Jimmy Carter having a problem during exercise about when my paper is going to be published. And then, whom my wife roomed with in college. So I've had a very interesting and fun career that's kept me interested because of a lot of lucky, fortunate sort of things that have happened.
So that's a lot to unpack there. And one of the things that you had said there was you'd rather be lucky than good. And that's kind of a phrase that resonates with my EMS friends, my ER friends. Sometimes we would just rather be lucky than be good. And I think everything does happen for a reason. And you went from long distance running and athleticism into the field of medicine, obviously associated the fact that the heart is a giant muscle and that those two are highly linked. And I think it's really fascinating that you made a career out of something that you were originally passionate about, that long distance running, and then found a way to just completely dive headfirst into it. And then, as you said, found your way in these unique situations.
It is interesting. I want to make sure that people understand that I don't think this is like something that I chiseled. I've had what I consider a very good career. Now I was at Stanford, I was at the University of Pittsburgh, I was at Brown. I'm now at Hartford Hospital as Chief Cardiology Emeritus, and at the University of Connecticut. But I was never at one of those places, like I worked at Mass General after I retired for 3 years, but only 1 week a month. But I've never been at really the top places. So I don't want people to think that so I'm proud of that, because what I got, I usually drove myself. In other words, I was the driver behind many of these studies. It wasn't, I call them group gropes, where you're at a very good place and just by hanging around, you get your name on a couple hundred papers. That hasn't happened to me. On the other hand, I do like to point out that a lot of things that happened to me were of luck. And I think all of us need to do that. I really always am not happy when people consider themselves a self-made man or woman, because that it we all get where we are from people helping you. Like, I've had amazing mentors, people that taught me things or looked out for me. One of the pieces I wrote in my blog was about a cousin of mine whose father had some trouble, and so he grew up without a father. But and I lost track of him for almost 60 years, and we've gotten together recently. But the men in that community helped him. They helped him go to where he became a highly decorated Air Force colonel. Couple of points. None of us ever do anything alone. So please be grateful. We're lucky, and people help us. And the other thing is, pass it on. I really have a problem with people who think of themselves as self-made people, because they're ignoring all the luck they had and all the people that helped them. I say that gratitude is the shortest lived human emotion. I've done some things for people, gone way out of my way, and almost immediately they forget about it. Watch yourself. Make sure you say thank you to people, because you aren't nobody's where they are by their strength alone. They had luck, and they had people helping them, and no matter what your religion is, the grace of God.
Absolutely, absolutely, and I think you're correct there. People put work in and try to set themselves up, and you can do all that. And yes, there are a lot of people that achieve greatness through that pathway. However, I don't care who you are. At some point or another, the stars just aligned just right for things to, come together. And I think you're 100% correct there, without a doubt.
You
Luck
know,
does play a little bit into that, and probably more so than people would like to admit.
right, it does. And I want to point out that I've been very lucky, and also very lucky who I had for parents. Like, my dad was a Baptist minister, so he was a learned sort of guy. I'll tell you a funny story. You may get a kick about this, and a lot of this stuff is in my blog, which I will push, called 500 Rules of Cardiology. It's
Yes, sir.
free and worth every nickel, because it's free. But anyway, my dad was a Baptist minister in Danvers, Mass, and he would go to the library most Wednesday nights to work on his sermon for the coming, Sunday. And so I read most of the dog books, which I was interested in, and then there was nothing to do. So I started reading the Olympic books. Now, this is well before my run with Bobby Blanchard. Um, but I read all after the Olympics, it used to be that the track and field folks would put out a book with everybody that won. And basically there was only track and field and swimming. So there were equestrian, there were some other things, but it was largely track and field. So I knew basically everybody that had won everything in the Olympics who was an American. Okay. So let me see if I can get this straight. So a kid comes in to see me with a medical problem, and the family lets me use their name, and his last name was Ashenfelter. And I said to him, wait a minute, are you related? That's an unusual name. Are you related to Horace Ashenfelter, who won the 1956 Helsinki steeplechase in the Olympics? And he said, that's my grandpa. They told me you were the guy to see. So, almost nothing you learn or do in life turns out to be useless. Sometimes medical students or residents will say, well, why do I need to know that? And I say, I don't know. I don't know why you need to know it, but you might need to know it. So it's you've gotten in my blabbing, you've gotten my what people call Thompsonisms, which is the stories I tell and the purposes that they have.
No, and I
No,
think
and
they're
I think
very
they're very
important to
important to
continue those
continue those
stories and
stories
pass
and
those
pass
on.
those.
And one of the other things that, and I don't want to let it go because I thought it was really important, and you had said it, passing information on and not kind of, gatekeeping information. And that's one of the biggest things that I find in medicine. There are a lot of people out there that are just willing to teach and willing to pass on that information. Of course, there are the few that just, feel like it's all about them, and, you're not gonna fix those people, but that's one thing that I really enjoy about medicine is that you have that ability to really pass on a gift that has been given to you. And I would love to ask you to take me back to that moment when you went from, student and, early physician into now all of a sudden you're on the other side of that podium and have that responsibility to now, teach and pass on this information. I'd love for you to just tell me a little bit about that moment and what you remember about that.
So, John, not before I come right back at you, because things like this podcast, and I was explaining to you that I don't understand this stuff all that well, but some things like this podcast, where you take and try to educate other health professionals, is a very important thing. And I want to compliment you on doing it. It's not easy because my Substack thing, no movies, no video is still a lot of work for me. So I want to compliment you on that.
Thank you.
Now you made a little bit of a mistake. You said when
Oh,
I was a student, and let me tell you, because I'm still a student. And I
okay.
learned something and one of the reasons I continue to practice medicine despite being age 78 is that I learn something nearly every time I'm on call with the interns and residents. And so let me give you a little example. Last week we were on, and there was a woman who came in with profound bradycardia. Her heart rate was in the 30s. And so I'm always, why did this happen to you? Why did this happen to you? She didn't need a pacemaker. She had no symptoms, but the slow heart rate was really bothering everyone. I said, look, have you changed any medicines lately? And she said, yeah, I'd been on Adderall for years and I stopped it about 10 days ago. Now, a lot of your people will know that there's something called beta blocker withdrawal. When you block beta blockers using something like metoprolol, for example, the body's not dumb. It makes more adrenergic receptors. So if you withdraw the beta blocker, you have a rebound, beta blocker rebound. It was first described in the 70s with some of the early beta blocker drugs with propranolol. So I said to myself, geez, I wonder if you can have a a, a rebound when you withdraw a catecholamine like Adderall. Adderall used for attention deficit disorder is a stimulant, stimulates adrenergic receptors. So I looked it up, and indeed you can. You can get bradycardia from the withdrawal of Adderall, according to Dr. Google. Okay, so I didn't know that. But when you're practicing all the time, and if you constantly ask yourself not what the patient has, obviously you need to know what the patient has, but why? Why did that happen? And if you constantly do the why, you'll learn a lot of stuff. And so both the resident that I was cardiology fellow that I was on with, and I learned something new. And I'll use that to, and it makes sense. I want to make sure I check it out. So this is kind of preliminary stuff. This was kind of the quick Dr. Google search. I looked at the artificial intelligence in Google, but then I always go beyond that because it's been wrong for me rarely, but occasionally. But it's something that a lot of people don't know about. I certainly didn't. So the point is, you have said, what did I make the switch from being a student to an educator? And the answer is never. Now, why do I like to teach? I call it the 4 T's. Teaching teaches the teacher. If you teach, that is the best way to learn. Second point, you want to improve medical care? Be a good teacher. If you teach somebody something that's useful, you could save them from making a mistake. There are a couple other things I think are important. When I walk around the hospital, it drives the residents nuts. I say hello to everybody. Hi. And they said, why do you? And I said to them one day, the reason I do that is that I want people to know that I'm approachable so that if they have a question, they can ask me. I don't know if you watch these. I love to watch these financial shows on TV. And I've noticed over the past couple of years that it always, when they get asked a question, they say, that's a good question. Now, sometimes it's a terrible question. They've obviously been taught that, but it's something we as clinicians should all learn. Because if some resident or a colleague asks you a question and say, really, you should know that. You don't know that? They're not going to ask you a question when they need it. And I've seen mistakes made in medicine. When I've gone, when I was the chief and I've gone to the resident, or sorry, I've gone to the cardiology fellow. I said, why didn't you ask X? Well, every time I ask him, he said, you're a second year resident, a fellow. You should know that. So if you put somebody down when they ask you a question, that's dangerous. It's actually dangerous. Now, suppose they make a mistake because they didn't ask you something, and they didn't ask you because you were difficult when they asked. Whose fault is that? Is it cardiology fellows? Yeah, of course it's the cardiology fellows. They're going to get blamed, but it's also your fault as a teacher who didn't make yourself accessible. So I think teaching is critical. Also, sometime in the past, someone said to me, "If you want to improve medical care, be a good teacher," and I really believe that. So compliment to you for doing this podcast.
Well, thank you.
And we
Yeah,
should
my
and we
my
should we should get off my life and teach people something useful.
No, I think it's really fascinating, and I love your approach to it. I think, I had a mentor early on, and a lot of people looked at him as kind of like this gruff, not overly approachable, and I was like, no, like that's not him. And I think you just need to look past that and not be afraid. And let me tell you, he became one of my strongest mentors to this day. I still call him, ask him questions. And I think you're right. You're never done learning in this field of medicine that we all love, and I think that's also kind of what keeps us going, you know? So after so many years, is there still one disease process that still really excites you?
I like medicine in general. I really like cardiology. Okay.
Of
I
course.
really like I really like how I'm very interested in how cholesterol drugs affect skeletal muscle. They do affect skeletal muscle, but very rarely, and they're wonderful, wonderful drugs. But I think it's interesting, the physiology. Statins are good for the heart. Statins appear in a lot of studies to reduce things like atrial fibrillation, the irregular, and they seem in some studies to reduce extra beats from the ventricle, premature ventricular contractions. But we've showed I had an NIH study looking at how statins affect exercise capacity. And what we found is that that the placebo people, about 5% of them complained of muscle complaints. And the statin folks, and it was double blind and all that sort of stuff, 420 subjects divided between 80 milligrams of atorvastatin, big dose, and placebo. And you couldn't tell the difference. About 5% of the placebo people had muscle aching that sounded just like statin muscle aching, and about 9% of the atorvastatin group. So the difference was only 4%. But so statins can affect skeletal muscle. I've had an argument with some famous people about this for years because we always thought it did. And our study showed that, but a lot of people think it's all in people's heads. A lot of it is in people's heads, but really, who cares? You can't tell a person, if you're a doctor, I don't care if it hurts you, just take it, because that's kind of doesn't go very far. So the point is, it's very interesting. How can statins cause some muscle aching in people and yet be good for the heart? And there's the something called the ryanodine receptor, and the ryanodine receptor is what regulates calcium going in and out of muscle. When you contract, you release calcium, and that causes the muscle to contract, and then you have to reabsorb it. The ryanodine receptor is related to all that calcium stuff. The ryanodine receptors are different between the heart muscle and the skeletal muscle, and there are a bunch of studies now that suggest that statins have a different effect on the heart muscle. They reduce the release of calcium in the heart muscle, so that reduces those extra contractions. They increase the release of calcium in skeletal muscle. So maybe you do get more cramps, maybe you do get more aching. But it's stuff like that. It's continuing to find little things. Now, let's talk about that a little bit. We just talked about you don't know what you need to know. If I were a medical student, I'm studying the ryanodine receptor and I'm going into cardiology, back then I may not have thought I needed to know it. But I'm really glad that I studied the ryanodine receptor when I was at medical school, because it's turned out to be useful.
If I had a nickel for every time I said, "Why do I need to know this? This is way beyond my know," I'd have quite a few nickels, and I think it's funny that you just said that because so many times, it comes back full circle, and you're like, "Hey, you remember that time we were talking about this?" And you don't remember anything about it, but here we are, and yeah, it always comes full circle one way or the other.
Yeah. One of the things that concerns me a lot, John, about medicine and physicians at the present time is this great, burnout that physicians have, and I understand it because when I'm on call, it is really quite tiring and patients are quite difficult. We've been talking about gratitude, but those of you out there who are patients, uh, please show some gratitude to your doctor. But if they treat you well during a visit, make sure you thank them. And the other thing is, be good to the staff. I had this guy who used to come up from New York to Hartford to see me. And, he used to complain to me about how hard it was to get up an appointment. And I didn't think it was that hard. And so I talked to my staff and I said, he's miserable to us. He yells at us. So remember who runs the show. It's not the doctor a lot of times, it's the staff. So, um, be good to them. I'm going to do a blog at some point, John, on how to take care of your doctor. Because, we think that your doctor's taking care of you, but to some extent, you're taking care of your doctor as well. I mean, patients can help me do a better job. Yeah, and I think that's an important thing to be a good patient.
Absolutely, it makes
Everybody
the
thinks
job a little easier.
it does, but everybody thinks doctors are making gobs of money. Well, compared to somebody in finances, your internal medicine doctor is not making gobs of money, is facing malpractice threats all the time, is facing people that don't do what they want, argue with them, all this stuff. It's not an easy job. And you can understand, and, dealing with electronic medical records. Now, so many of us bring our work home because it's so hard to finish a lot of the notes in the electronic medical record. So show some gratitude and take good care of your doctor. Thank them if you get a good deal because it's hard to find internal medicine doctors or general care doctors now because a lot of people are going out of practice. I continue working because I like it, but also I think I do provide a service because it's so hard to find doctors.
Yeah, I think that we're at an interesting time right now, and I don't know what it is. I definitely don't have the answers or the solutions to it, but there is a sense of entitlement, unfortunately, with the general public, and I do think that we forget sometimes that physicians, nurses, paramedics, all the ancillary staff, like we're human as well. And it can be exhausting to do this line of work and sometimes to be taken for granted. And, we don't always have the answer. We don't always have the solution to your problem. And I think that's an important thing for people to understand.
Yeah, I think the nursing uniform should include halos. Oh, really, seriously, why not just have a little thing that's immediately put on the back of your blue well, all the nurses at Hartford Healthcare wear blue. Why not have just a little thing on the back of your collar that has a halo over your head? I mean, really, I am so grateful to nurses. The number of times they've prevented me from doing something wrong, the number of times they have uh, gotten extra care of patients and made me look good. I am so grateful for them. And also, the other thing is that, especially when I was younger, the number of things they taught me that I never would have learned from an attending physician. Amazing.
Yeah, it's a big team, and like I feel like sometimes we lose the sense of that. And at the end of the day, we are one big team trying to achieve one goal, and that is to provide a better outcome for somebody else, like to improve somebody's life, whether that be mentally, whether that be physically, through exercise, through cardiac care, through respiratory, like all of the above. We have one goal in mind as a one big team, and I feel like if you forget that sometimes, winning that game can be a little bit more challenging than it already needs to be.
Yeah, I agree. Another thing, John, that I've actually talked about is saying good things about other clinicians. Because a couple things. One is that, if somebody's really a good doctor or they did something smart, I always say to the patient, you're really lucky that John Joe, Dr. Joe found that or something. Make sure you tell him that. So, number one, the doctor gets positive feedback. That makes it easier for that guy, the doctor or the gal, to be a good doctor because the patient is more likely to listen to them next time if they've been assured that that's a good doctor. And then the other times, the number of times that doctors have called me up and said, that patient you saw said that you said I was a good doctor. I appreciate that. Nobody ever says that, and I'm glad to hear it. So, positive feedback about other doctors is a good thing to do. And then the other rule is don't ever say anything negative. A lot of malpractice cases, and I'm not against malpractice. I think patients who they've been harmed should be, get what they deserve. And I've made mistakes. I mean, everybody makes mistakes. But, sometimes saying something like, he did what? Or, really? They did that to you? I mean, don't do that. You don't need to do that. And never saying, just um, you can start a lot of malpractice cases just by, saying things like that. And who the heck do you think you are? I mean, you weren't there. You weren't taking care of the patient. Sometimes I've done things in the without full knowledge because the knowledge came later on that in retrospect were mistakes. And so you got to give the person a benefit of doubt. Don't be good to your colleagues. You talked about the team. But being on a team is you got to be a good teammate.
It's really easy to be a Monday morning quarterback, right? We've all heard everybody, "Oh, they did this way and da da da," and it's like you said it right there. Like you weren't there. Don't try to, put your 2 cents into something that's not gonna create anything but negativity. It's like just bring positivity to the situation. If not, just kinda keep your trap shut, you know?
Right. We everybody always used to say, if you can't say something good, don't say anything. And it's the way my parents were. Now, I mean, none of us do that anymore. I mean, everybody moaning and groaning, but it's not a bad idea to at least think about that possibility of not
Right?
saying anything negative.
Some of the sayings from back in the day, they carry some weight that I do wish were still a little bit more, circulated, if you will.
Yeah. And I'm big on being kind. Kindness goes a long way.
So, Dr. Thompson, I wanna take a little bit of a turn here, and we've talked about it a couple of times. You've brought it up, but I want to kind of deep dive a little bit. Your 500 Rules of Cardiology. I started going through that, and I've read some of the blogs that you've posted. I think it's fascinating. It's amazing the level of knowledge that you bring to that. So I want to ask you, what was your intention behind creating this blog? Because as you already said, it's exhausting. It's a lot of work to maintain. So yeah, tell me a little bit about what your intentions were behind this.
So, I've learned a lot of things over my lifetime, and in when rounding with interns and residents, sometimes they would call them Thompsonisms. And residents and fellows over the years have said you should write these things down. So before I exit this earth, I decided I would try to write these things down. Because medicine is interesting. It's fun for me to write them down. And like I told the story of that Ashenfelter individual, and I do that in the blog. I've written about some of those things. So some of it has some personal stuff to it, but mostly I did it because I would like to pass on these little things. I had great attendings and teachers growing up. I wished I had had an attending like me who really was interested in teaching. I think there are a couple types of people. There are some teachers who teach to show you how much they know, almost as a put down. And there are some people who teach because they want to build you up. I've really, I don't mind showing what I know. I mean, I'm proud of what I've learned, but my real goal is to get those things written before I, exit this planet because nobody gets out alive and I want to write them down before I before I forget what's going on. Before I start drooling the oatmeal, as they say.
That was a good line. Nobody gets out alive.
Yeah, it's true. It's true.
Oh man. Well, no, I think it's important work that you're doing with that blog, and like I said, I've enjoyed reading. Some of it's a little over my head. I'll be honest. Some of it, I'm like, oh, this totally makes sense. So, for anyone that's interested in learning a little bit more of some of Dr. Thompson's work, check out the 500 Rules for Cardiology, and I'll make sure to put the link in the description below and all that stuff.
Thanks. It's free. I've been trying to do it. I'm doing it free simply because I want to, get that stuff out. And we have almost 6,000 subscribers. And John, if I do things that are too tough or too over your head, make sure you email me or make a comment because look, I'm not, like all that smart. And
Just a little bit.
I've learned all this sort of stuff and understand most of it. So if I can, you can really honestly.
Well, I appreciate that, and I will definitely not forget that.
But
So,
if you can do this podcast, you can because I can't get the podcast stuff down at all. So if you can do that, you can understand my blog, guaranteed.
Well, when you have a good guest like yourself, it makes it a little bit easier. It's just like having a conversation, you know?
Yeah, well, it's my pleasure.
Absolutely. So I want to ask just kind of point blank, I'm approaching 40 years old. You're a world renowned expert cardiologist, whether or not you want to call yourself that or not, I will. What is one thing I could change, or someone that's listening that are in my shoes or younger, older, either way? What is one thing that somebody could make a change to just improve their overall cardiac health from your perspective?
So usually, you said something you could do because I usually tell people that the most important thing to do is to pick better parents. Okay. Because so many of the things, even probably our response to diet and our response to a lot of things, is partly dependent on who we pick for parents, how good you can get as an exercise and stuff like that. But if you ask me, probably the one thing, it's to keep your body weight under control. If you then gave me the second thing, it would be to be physically active, to do something every day, especially as you get older, like at age 78. I mean, I am very deliberate about getting to the gym as many times a week as I can. There's sometimes I'll go a month or so without missing a day of going to the gym. And you can't tell by looking at me because I'm skinny and I have no muscle, but I try to build muscle. It's just, I think genetically I'm of that sort. But I think keeping your weight down. So why is keeping your weight down such a big deal? Weight drives diabetes. The bigger you are, fat cells fight insulin. So if you've got a lot of fat cells, that makes insulin's job more difficult. Weight is related to blood pressure. Weight is related to osteoarthritis of the hips, the knees, the ankles. You're heavier, you put more stress on them. So one of the most important things is the weight thing. Then the exercise thing. I think exercise is very good for disposition. There are people who they call themselves exercise addicts, but really they are addicted to exercise because I think a lot of people are not manic depressive, but they have up periods in their life and they have down periods in their life. And what they learn by being physically active is that they can eliminate a lot of the downs. It doesn't get rid of being, having tough times in your life, but it gives you a sense of having done something. So, like, I deal with a lot of athletes and I've watched this, and it's interesting. A lot of very competitive middle-aged athletes were things like drinkers beforehand. In other words, they had addictions to other things and they got addicted to exercise. It's one of the reasons that even when people have pretty severe heart disease, I don't totally stop their exercise. I get them doing something else so that they can keep it. But so the weight loss is a big deal because of all the things it affects. Fatty livers, for example. Bigger people have fatty livers. Why? They have more fat to mobilize to go to the livers. Bigger people, cholesterol level not as strongly related to weight, but it is related. And so all these things related to weight. Then an exercise program. Diet is critically important, but I find diet a very hard thing to do. If you decide to make a dietary change, you're making 100 decisions a day or so. Eat this, don't eat that. You could be good all day. You go buy something, you eat it. It looks like if you cheat. So example, if you're trying to lower your LDL cholesterol by reducing your saturated fat, and how do you know a saturated fat? When you meet one on the street, it's hard at room temperature or hard very rapidly on going into the refrigerator. So saturated fats are primarily from the milk and meat of animals. There are also some saturated fats that are in vegetables, but they're tropical vegetables, like things like palm oil, not coconut, palm oil, cashews. So tropical fruits, tropical nuts can have a lot of saturated fat. So if you reduce your saturated fat intake, what does that do? The liver makes more LDL receptors, these little grabbers that grab LDL cholesterol. But if you cheat a little bit on your diet, that suppresses the LDL cholesterol receptors, and you don't have to cheat a whole lot. So I think it's very hard to do all these things with diet unless you have great control. If you've got kids, you have no control. Your life is ruined. So, so I'm a drug dealer. I mean, they're all legal, but I admit that I'm a drug dealer. Medicine isn't a morality play. I don't care if you got there by hard work and by worshiping God. I care whether you got there. Did you get your cholesterol level down? Because if your cholesterol level's down, you're likely to live longer. Did you get your blood pressure down? Because you're likely to live longer. Did you get your weight down? Now that we have these, GL, uh, glucagon like peptide 1 agonists, Ozempic, those sorts of drugs. So I'm a drug dealer. I try to get people well and keep them well. What can you do? Do the best you can in keeping your weight down. Now, what I do is I only eat 1 meal a day. Now, this is controversial. Okay, so you're ready. I'm not nutty. I'm not too nutty, but this is what I think. When you a Cro-Magnon man, if you were hungry and crazy hungry, in other words, you haven't eaten and you're crazed about getting some food, and you went off and hunted the woolly mammoth all alone, your genes were not passed on. You were killed by the woolly mammoth. So when you're starving, you break down fat, and that gets made into ketones, and ketones are appetite suppressants. When you don't eat overnight, you generate ketones. Okay, most people don't wake up in the morning, I'm famished, I gotta have that cereal. Um, so if you can skip breakfast, which I do, and skip lunch, which I do, and then I eat dinner, I got up when I was running competitively, I weighed 125 to 130 pounds, and I'm 5'7". I got up to 168 pounds, and my wife mentioned that she thought I was pregnant. I was not. Now, there are two reasons I was not pregnant. One is I'm a male. We won't go into the other one. Okay, we're not going to talk about that. But the fact of the matter is that I got my weight actually too low. I got down to about 140 where I didn't feel so good, but I keep my weight about 150. So I haven't had breakfast today. I did have a coffee after the gym. I had a Starbucks coffee, 350 calories. That's what I'll eat and consume until dinner at about 5 tonight, until I start eating dinner. And you actually don't feel that hungry. You don't feel that hungry because you keep ketones around, which suppress your appetite. Now, if you do these sorts of things, now there's also people who do the ketogenic diet. I'm less a fan of the ketogenic diet in which you eat a lot of saturated fat and animal products and stuff like that. And I'm less a fan of that because some people, not many, but some people can get markedly high cholesterols from the ketogenic diet. Now, generally not. But if you do a ketogenic diet, I guess whatever they call it, maybe it's a South Beach diet. I don't know what they are. But if you do that, make sure you get a cholesterol level measured so that you can see that your cholesterols are not sky high.
So a lot to
Anyway,
again unpack there. One of the things that you mentioned initially, right off the bat, was keep the weight off. And there are several ways to do that. And I know exercise is really big in your background. Obviously, diet is a component there as well. And I think you nailed it right on the head when you said that changing your diet is like making 100 changes comparatively to maybe going for that one walk per day. That's a much easier goal to really achieve, because I personally have been up and down that road like everybody else, where we go a little overboard, where we don't eat all day, or maybe we do, but we don't do it in like a very controlled way like yourself in that intermittent fasting. And I think the way you said it was just brilliant, of keep the weight off. And I think that the take home point isn't necessarily the one method to achieve that. It's, find the balance in what that looks like and be able to achieve it consistently. Is
yes,
that
it is.
accurate?
It is accurate. Exercise alone, unless you do a ton, is a hard way to get a lot of weight off. It really is a hard exercise alone. So, you have to walk about, if you're a 150-pound man, you have to walk about 34 miles and not eat any more to lose a pound. Because a pound of fat has got it's got a lot of calories in it. Okay. And I think that's the correct, I will have to check. Don't quote me on that, folks. You have to check that. But you have to go a lot of miles to burn up a pound of fat. But it helps keep the weight off. Now, I always tell people that I want them to walk, not ride a stationary bicycle. Why? Because what's their problem? Their problem is they're overweight. So if they're overweight and they walk a mile, they use more calories. They burn more calories than I walk a mile. So I say, look, you got this lemon, and point to their belly. Let's use it to make lemonade. If you can walk 3 miles, you use almost double the calories if I walk 3 miles. Now, what about the difference between running and walking? The calories are different. You use more calories per mile running because it's more inefficient. Walking's more efficient, but you can run more miles as well. The thing about walking is you use about the same calories. It just takes longer. So, a more vigorous exercise helps a lot. Right on bicycle riding. Bicycle riding is a machine, like when I would run 10 miles, what would I burn up? I'd burn up about 1,000 calories. I go ride 10 miles and I look at my Strava and it says I've used like 400 calories because you're using a machine which makes you more efficient. So it's very different. Even though you go more miles on the bike, you don't. And biking, for example, the wind resistance makes a big difference. So in order to burn more calories riding a bicycle, you either got to go uphill or you got to go fast into that wind to face the wind resistance. The same thing as what was swimming. Swimming, you burn more calories the faster you go. Walking and running, not so much. Speed doesn't matter so much. It matters, but not so much because you burn more because the running is less efficient, but you don't, both of them, you burn about 100 calories a mile, roughly. I think for running a 6-minute mile for a 150-pound man, it's like 98 calories. Running that mile for a 150-pound man is 119 calories. So about 20% more expenditure. But the issue is, if you're a heavy person to do that, you're likely to wind up with an orthopedic issue.
Well, it's funny you just mentioned that because, when I was going through my weight loss, journey, if you will, where I was just a little overweight, I wasn't, heavy by any stretch of the means, but I found that running was kind of high impact on my knees, and I didn't enjoy it, and I found myself like not really committing to it. However, in between each weightlifting session, instead of sitting there and pulling out my phone and doing the thing that most people do, I got up and walked from one end of the gym to the other. And that alone added, thousands of steps over time that I think really contributed to me, shedding some of that additional weight alongside of, the weightlifting and things like that. But running on that treadmill, it wasn't for me. So I
Totally
kind
get it.
of, went that road instead.
Yeah, a great thing to do is if you have a basement that you can put a treadmill on a TV, you can watch the playoffs by walking on the treadmill. To get the equivalent of walking outside, you want to have a 1 or a 2% grade on the treadmill because when you're walking outside, believe it or not, you actually have a little air resistance if you're moving along pretty quickly, and you can mimic that air resistance by raising the thing a little bit. One of the guys I mentioned, Bill Haskell, wonderful person, wonderful human being, still alive at Stanford. He calculated at one point the number of calories saved by email as opposed to getting up in your office and going to somebody else's office. And it was really quite enormous. I try when I'm in the hospital to always take the stairs. Now, I do that for two reasons. One is it's quicker usually than the elevator. And the other thing is it gives you some exercise. It's kind of notorious among our cardiology fellows that, oh no, Thompson's on, you're going to be taking 10 flights of stairs every time you need to go to the CCU. But that's what I do. Now, I always say to them, you can take the elevator if you don't mind. I'm just going to go up the stairs.
Well, I love the fact that most hospitals posted in the stairwells now, like the amount of calories that you burn from each stairwell.
Really?
So it's that little bit of motivation sometimes is all you need to be like, you know what? Let's take the stairs this time. And it's always easier going down them, right?
It's always easier going down. Yeah, it is easier.
That's usually when I'm like, let's take the stairs.
Somebody has written I heard this at the American College of Sports Medicine, which is a great organization. I try to go to their annual meeting, but there was somebody talking about exercise snacks. Sometimes we always are looking for the exercise meal. I'm going to go to the gym and work out for an hour. But if you can get little exercise snacks, if you can do little things during the day. Now, it's hard because you'll be tired, and it's when you go to the gym, I mean, I'm there. There's no distractions. I'm going to do, and what I do is I set my Apple for an hour, and when that thing goes off, I'm out of there. But I don't spend a lot of time on my phone and stuff during that. If I have an exercise that's tired me, I go to another muscle group, and so that I really try to get 60 minutes of doing stuff, really being quite aggressive. It bugs me. A couple things bug me about the gym, so I'll give you my list of complaints. One is the people that sit down on the weight bench and use their phone, and I have to go over and say, "You're using this." And the other thing is the people that, largely women, who take like the 15-pound, the 20-pound, and the 25-pound weights dumbbells and go over to a corner to do their exercises. I'm a weak guy, so those are some of the weights that I want to use. I have to go over and say, "Are these your weights, or do they belong to the gym?" Or this one. What's my other gripe? Yeah, I think those are using the phone, taking the weights and going someplace. Yeah, and yeah, those are my gripes.
I love the gym. It's always an interesting time.
If you can get a buddy in there that you work with, like if you're one of those people, so you have to depend on who you are. Like I'm not social. I mean, I am social. I like to talk to people, but I like to have a purpose in it. So I like to go to the gym. I wouldn't work out with somebody else. I just go there and work out because, well, I'm waiting for them to do their set of the exercise. First of all, there's probably nobody I could go to the gym with that lifts weights as light as the ones I do. I'd have to be going with the women. My wife won't go, but so she will go, but not with me. So but yeah, if you can get some, depending on your personality, you got to figure out what your personality is, what floats your boat. If you like doing it with somebody else, well, get a buddy, and then the two of you can motivate yourselves. But I think exercise is especially important as you get older, because you can outlive your muscles. And then look at all the things that having good muscle does. First of all, you get rid of sugar in muscle. The place that chews up sugar is skeletal muscle. Um, you know, uh, free fatty acids go to fat. Sugar gets burned up primarily by muscle, or it gets stored in muscle as glycogen. So getting your muscle chewing up glycogen and chewing up glucose every day is a very good thing for your blood sugar. The other thing people need to know is this. So let me tell you about a study we did. We did a study in which we measured what happened to your triglycerides the day after exercise. So the day after exercise, if you exercised for 30 minutes, the day after, your triglycerides were a little lower. If you exercised for an hour, they were a little lower. Now, these were untrained people. Then we took trained people who could exercise for an hour but do a lot more work. So here's the untrained, half an hour, hour. Here's the trained people, an hour. Then you can't see this, but 3 hours. So the more exercise you did, the lower your triglycerides were the next morning. Why? Because when you exercise, you burn up fat in muscle and around the muscle, and then you have to replace it. So you turn on this enzyme, lipoprotein lipase, that takes the fat, the triglycerides out of the same thing happens with glucose. If you exercise really hard today, your glucose is a little lower tomorrow. And blood pressure. If Linda Pescatello at the University of Connecticut, one of our collaborators, she showed that if you did vigorous exercise in the morning, like 30 minutes of really intense exercise, your blood pressure is lower for the rest of the day. So what's my point? You didn't need to get into shape. You just needed to do one exercise session. Now, over time, as you get stronger, that one exercise session can be more intense, longer, and just do more work, and you get a bigger effect. We think some of the effect that people get from exercise training on glucose, triglycerides, good cholesterol, all that stuff, is a summation of individual things. Now, one other thing, there's this book, I don't remember what it is. Oh, Atomic Habits. A great book. And what it talks about that habits are built from very small things. So suppose you don't have time to spend an hour in the gym. Do 5 minutes or do 10 minutes. And sometimes those 5 minutes turns into, well, you know what? This is kind of fun. I'll do 15. So just, one of my, I have I always make up rules. So I have these 10 rules of research. And rule number 2 is, I don't care what you do, just do something. And that's true of life in general. Too many of us, we wait until we're ready. Well, if you're waiting till you're ready in life, you know what? You're going to wait because you're never ready.
I forget this saying that's like it's something along those lines of like procrastination, and I fully appreciate it because I'll sit there and stare at a project and just keep staring and like magically hope that something happens, and nothing happens until you actually get going. Like you got to put that work in, and it's like the snowball effect. And I think you're right with exercise, whether it's diet, any of the above. If you just start off by making one small change and stick with it and remain disciplined, that snowball effect is just going to carry through because you're going to start seeing those benefits. And I think that's very powerful comparatively to just, oh, I'm going to change everything overnight. Like, no, you're not. No, you're not. You're probably gonna go hard for those few days, but that's gonna burn out real fast. And it's harder to actually see true gains that way comparatively to just small changes over time.
Yeah. What was that movie with Dreyfus in it years ago about the patient that followed a psychiatrist on vacation, and it was baby steps, baby steps. You just need to
What
make
about
baby.
Bob?
What about Bob? That was it.
Yes.
Baby steps. All you need to do is baby steps.
Absolutely, absolutely. So, Dr. Thompson, I have one final question for you, sir. Before we go, I do just want to quickly, once again, promote what you're doing on the side here. You have the 500 Rules of Cardiology. You can find that. I will definitely have the link in the description below. You are on TikTok. I know you said that you may not be tech savvy, but that's how I discovered you. Like I said right from the get go. I am looking forward to more of those. Is there anything else that you would like to talk about before we get going here?
No, I just want to compliment you on doing something interesting like this. I hope I've taught people something. It seemed a little too self-indulgent in terms of talking about myself and my career. But there are lessons for all of us, and I'm just grateful, and so I'm grateful to be included. So I just encourage people to pass on kindness.
Well, I appreciate that, and thank you for your kind words. And yes, 100%. Pass it on. Don't be a jerk. Life is a lot better if you just kind. So my final question for you, sir: if it wasn't cardiology, what specialty in medicine would you like to study?
It's interesting. I would probably do neurology, and I would do skeletal muscle. Skeletal muscle is one of the biggest, if you put it all together, organs in the body. It does things we don't know. In other words, exercise releases these things called chemokines, or it's the chemicals that come out of the muscle. We don't totally understand all the things they do, but the skeletal muscle is very interesting. And now I'm telling. I'm I would also be much more of a genetic cardiologist. I think the genetic stuff is very, very interesting. So those of you out there who are interested in cardiology or interested in medicine, I know you can make a lot more money in finance and stuff like that, but I'll tell you, it's fun. Medicine can be a lot of fun, and you do something for people. And, a lot of people's lives are not as, people have tough lives, and you can get some satisfaction at trying to make them a little easier.
Yeah, I agree with that entirely. I never thought I would find myself in medicine. I never had any desire to be in medicine, and here I am 15 years later. So it's a wonderful career, and like I said, I couldn't agree more with you.
Good for you, John.
So thank you, Dr. Thompson. I really appreciate your time today, sir. I look forward to all of the future releases of all your media, from 500 Rules of Cardiology to TikTok to anything else that you get involved with. So again, thank you so much for being here today, sir. I appreciate you.
My pleasure. Thanks for doing this.
All right, have a great day.
You too, sir.